Hello, my name is James Lasky, and I'm so pleased to be hosting this three-part series about pressure injuries brought to you by Rehabtronics. I'm a retired professor of physical therapy from the University of Montana, where one of the subjects I taught was wound management. As well, I have a background in the assessment and treatment of wounds. I'm currently in Vancouver, where I do research in the care and rehabilitation of spinal cord injury, as well as I'm the researcher in residence for the Praxis Spinal Cord Institute's commercialization program, where I mentor companies engaged in emerging technologies for the care and cure of spinal cord injury, including a number of companies who have been focused on the assessment, prevention, and treatment of pressure injuries. The topics of this series are: what is and what is not a pressure injury? Second, what do we know about pressure injuries, why they form, and who is at risk? And finally, we'll have a discussion about emerging technologies for the prevention of pressure injuries. I'm very pleased to be hosting this series of 3 webinars, and I would like to introduce a very special guest and friend, Dr. David Armstrong. For many of you in this space, you already know Dr. Armstrong is a well-known and accomplished professor of surgery in the Keck School of Medicine at USC. He's the founder and co-director of the Southwestern Academic Limb Salvage Alliance. He's got over 600 peer-reviewed papers and 100 books or book chapters to his credit, and he's the founding co-editor of the gold standard text, American Diabetes Association's Clinical Care of the Diabetic Foot. As a healthcare provider at the top of his game and at the leading edge of wound management and limb salvage, Dr. Armstrong is the perfect guest for this series. Dr. Armstrong, could you please share with our listeners a little more about your background and interests specifically about pressure injuries?
Yeah, James, man, it's great to just chat with you. Thank you for letting me play hooky.
We always have fun, don't we?
Well, listen, after such a kind introduction like that, you can only be disappointed. So there we go. Buckle up. It really is. It's wonderful to chat with you. It's wonderful to chat with you about this, what I think would be, maybe we can agree, is a common, complicated, and to be alliterative, costly condition. Because it's one that very few people talk about, yet it affects so many people, not only in the U.S. but really worldwide. My area of specific interest is not directly as regards pressure injury. In fact, so I'm a podiatric surgeon. I'm a foot doctor, a toe mechanic, if you will, and I was recruited out here to Keck School of Medicine at USC with the big idea to eliminate preventable amputations over the next generation. And it's pretty awesome, and things are really moving along well, trying to generate these sorts of teams. In that context, we see wounds of all types, but very, very often, and especially in our patients with diabetes, we see pressure injuries for folks often that are hospitalized, but also for folks that are just sitting around the home and may not have the gift of pain to be able to identify when that problem shows up. And so this problem, pressure injuries, have long since been one of the banes of our existence. They are fascinating in that they're enigmatic, and that there are not a lot of people that really focus on them until they become very, very severe elements of tissue loss that can put not only people's limbs, but their lives at risk. And again, I think I run the risk of preaching to the converted by telling you this, James. But there you go. It's a pleasure to be with you. And thanks for putting this on, by the way. This is just great.
Yeah. The topic of this episode, which is one of the 3-part series on pressure injuries presented by Rehabtronics, is focused on what is and what is not a pressure injury. The objective of this episode is to set the stage for a discussion about pressure injuries and dispel confusion about what is and what is not a physical pressure injury. What are both typical and patient populations and settings that you may not think are typical in relation to pressure injuries? And what is the impact of pressure injuries on patients, caregivers, and families? So, David, as you already have mentioned, pressure injuries can be catastrophic and life-threatening, certainly have incredible effects on individuals in terms of independence, activities of daily living, work, just life in general. So you wouldn't think it we'd even need to have a discussion about what is and what is not a pressure injury. But as you know all too well, things get called pressure injuries that are not, and vice versa. So could you just give me, I'm your medical resident fellow coming to visit you, and what is the kind of Reader's Digest version, 30-second elevator pitch of what is a pressure injury?
Yeah, well, I'll just tell you by telling you what a pressure injury isn't. I'll also then talk about what a pressure injury is. So one of my great mentors was a surgeon who was born and raised raised in India of missionary parents. His name was Paul Wilson Brand, and he treated folks there with leprosy, with Hansen's disease, and people with Hansen's disease with leprosy often get tissue loss. But in doing that, he sort of came up with maybe 2 or 3 ways, or maybe 4, that people can get tissue loss, and it really does help to think about it when we're talking about how to define what a pressure injury is. What he used to talk about, he said, there's 3 ways you can get skin breakdown. The first way is by constant repetitive stress, and that's stress repeated constantly. And that's moderate pressure that ultimately leads to some inflammation and tissue breakdown. That's the most common way you can get a wound in someone with diabetes, for instance, on their foot, usually on the bottom of their foot by walking. The second way that people can get a wound is by high pressure and very few cycles of stress. So think about a needle going through skin, or if there is a bite injury, God forbid, or something like this, or even someone getting poked. That sort of injury is some sort of a stabbing type of injury, is one way people can get tissue loss, and it's quite common, especially in things like foreign bodies. If you step on a needle, God forbid, and it gets in your foot, we take those out on a daily basis in emergency departments and operating rooms around the world. The third way is, and then we'll get into the fourth way as well. Actually, let me get the fourth way out of the way. Fourth way would be like a burn injury, or any kind of chemical or thermal burn. So, but now let's get back to that other way about a pressure injury. Now, a pressure injury is just low pressure, generally speaking, low pressure and constant stress. So it can just be something like, if I'm just pressing on my hand, you can see how it blanches. It just blanches white. Now, that very, very low amount of pressure over a prolonged period of time in someone that doesn't have the ability to move out of the way because they are anesthetized, or if you're British, anesthetized, or if they are sick and unable to move, or if they're paralyzed or unable to move, or if they have something like neuropathy from diabetes or some other problem, and they're unable to feel the pain. So that low level of stress ends up leading to the magnifying both shear stress and normal stress over that area, inflammation, deep tissue injury, and ultimately full tissue breakdown that you can kind of see in this patient population.
People often think about shear and things like pressure, and I often think of yes, that's true, but I so often think of, but what sets it up? And it seems to me like sort of a Venn diagram of 3 things. It would be sensation, altered circulation, and altered mobility. And
I love it.
One of those 3 things. And I know I was really surprised as a young physio, with all the training that we get, in school, and I was doing wound care. And I remember getting a referral for treating a pressure injury of an older woman who had a hip fracture. And I'm like, hold it, like that doesn't fit all those things that I learned. And of course, it turned out that, she fell in the bathroom and she broke her hip. And so she couldn't get to the phone. So after 14 or 15 hours, somebody finally found her. So here was a woman who was otherwise healthy. It wasn't a spinal cord injury. It wasn't all those different types of conditions like diabetes where we think about getting a pressure injury, but she was immobile. She was laying on her hip. So she had the lack of mobility. She certainly had sensation, but because she was laying in a position, couldn't move, she had a circulatory issue. So she sort of nailed two components of that and ended up with a massive pressure injury. Are there some other conditions that you've experienced that are misclassified?
Well, sure. I guess, I think for me, the ones that are most frequently misclassified would be the ones that maybe started as maybe repetitive stress injuries, and by reversing that repetitive stress, one can treat the wound rather than by just that low stress over a long period of time. So that one for me, as someone that works in limb preservation, is probably the most common. But you mentioned intertriginous wounds, but even those, if you have something, that may have that, you might have something that has kind of low pressure and constant stress. If you had two body parts that are sticking together or pushing against each other, that can cause a pressure related injury. So let's understand that. It's just so you can get the mechanism of action happening in those sorts of ways too. But yes, those are frequently misdiagnosed.
Okay, cool. And I think, to be clear, the reason why we care is, one, to understand mechanisms of injury, which will help whether it's prevention on the front side, or it may affect treatment and what we do. And so
absolutely, the goal, that's absolutely right. The goal is to identify the etiology, just like we talked about, which is why I spent so much time doing that, and then to try to reverse as best as possible that etiology. That then will help that patient when he or she moves into what we call, remission.
Could you share a little bit about, just sort of off the top of your head? We won't hold you to it. We won't have to. We'll maybe fact check a little bit, but in terms of some of the statistics, like who's affected, what's sort of the demography or body shape type, like who are the people that we're most concerned about with pressure injuries specifically?
Yeah. Well, look, right now, pressure injuries, and I know you know this, James. I mean, you can elaborate on this as well. But right now, they kill more people in the United States than traffic accidents. It's an astonishing number, and people are talking about traffic safety all the time. We're not talking about safety in the bed, in the hospital, and in the home as much as I think we could. And that is affecting quite a lot of people, and it can actually affect people that you wouldn't normally expect. Maybe someone just going in for an urgent surgery, and maybe it's not someone with, say, quadriplegia or paraplegia. As you had mentioned, you had learned in your early days of training as a physiotherapist, or physical therapist to translate in the United States. But we are two peoples, James, separated by a common language. I think
there you go.
Not just a border.
So true, isn't it? So true.
But what we see now is this affecting, of course, younger people that might have catastrophic injuries from trauma, and older people who might be again having issues of mobility. Either they're hospitalized or they're immobile at home and have some, as you had mentioned, maladies that affect their sensation, that affect their mobility, that ultimately will affect their integument.
Right. And then the third one, sort of the third, pillar or the third leg of the stool would be circulation. So I often think about when I'm looking and trying to assess risk, just for myself with the patients I work with, I sort of think in my mind, okay, so how is their mobility? Are they able to move? If you're able to move in bed or in your chair, like you and I sitting here for the next however long, like we're not going to develop a pressure injury because we're shifting around, even like micro movements. But also, I find it interesting that people often are surprised put it this way, healthcare professionals are not surprised when the sort of more lean, thin individual gets a pressure injury. And they're often surprised when somebody who is got a little more meat on their bones, could be not even obese, but a little more weight, or even those who are obese, they think, well, but pressure injuries, that's just pressure and weight and pressure on the deep tissue to the bone. And if they have lots of tissue, well, then they're okay. And that's so not true.
You look, yes, I think to make everything very, very short, you are absolutely right. That bottom line is that this affects people of all shapes and sizes, and even all ages. But the vast majority of the patients that come in to see us are people that have very severe complications of where they have ischemia as well, and that just is part and parcel of what we're dealing with. And this could be macrovascular disease, the big vessels kind of running into a body part or around one, and then micro, that involving the actual tissue perfusion in the end organ of the skin itself.
Right. Yeah. So I think one of the topics I wanted to talk a little bit about was comorbidities. And in terms of the historical context of pressure injury, kind of what have you seen in terms of how we recognize pressure injuries, how we assess pressure injuries, and maybe a little bit about how we treat pressure injuries?
Yeah. So I think early on in my career, I think pressure injuries were often completely missed. And it wasn't through the fault of any woman or man. It was through, it was a systems issue, really. It was just that folks were, coming in and we were focusing on life and limb, and these areas of almost at the periphery, just the points of contact, maybe where the patients were largely ignored in favor of just keeping that person alive. And by the way, that's still true in that, life and limb. Life over limb, and but we're still focusing on this sort of thing. That, however, has dramatically, I think, improved thanks to not just to new technologies, but to organizations like the National Pressure Injury Advisory Panel, the NPIAP in the United States, and many other. The European equivalent and the worldwide equivalent has really improved awareness about this problem. But let's just say the problem still exists, as I mentioned. This is not just a problem that costs an enormous amount in terms of economic costs. This is a train wreck because it affects more people than car wrecks.
So just to wrap up, the last component of this episode is the importance of prevention. It seems like a really foolish thing to talk about because, of course, I mean, we don't want them to happen in the first place. So can you share a little bit from your perspective, sort of why is prevention important? What is to gain from prevention? And what are some of the prevention strategies, both from your practice in the area of diabetic wounds that are related to pressure injury, but also broader, and maybe thinking of the advisory panel? So what are some of these strategies that we're doing these days?
Yeah, so I think I don't need to tell you that an ounce of prevention is worth tons of cure in this area. But again, I will just say this: one of my friends who I was just with very recently in England, this last week, my friend Nicholas Schapper, who's from the Netherlands, said we need to do what we say we're already doing. So that's what he's sort of famous for saying. Here's what he's sort of famous for saying.
About all parts of our lives, couldn't we?
Yeah,
practice what we preach or teach.
that is absolutely correct. He's sort of famous for saying that many years ago. He said it again last week. But I will tell you, significant efforts that we're doing and we're working on doing, not only at our place, but really around the United States, around the world. And that's first of all identifying people that are at risk, and if we can identify people that are at risk, maybe that have some skin that is at risk, maybe identifying that, getting these people into the appropriate ward to where we can have patients adequately surveilled, adequately. And this is so easy to say, and it's hard to do when women and men, nurses and techs and physicians and surgeons are already overworked and burning out. But identifying those folks and putting resources and putting bedding into place that can identify these things and maybe move people periodically. So doing that early on, maybe even on screening when a patient comes into hospital, first
Right.
thing, so the problem can be present on admission, or the issue can be identified. If they are at home,
Right.
making sure that they have the appropriate orthoses and bracing that can offload an area and protect an area. Make sure that we have the appropriate bedding and surfaces there. If they're in a wheelchair or some sort of other aid, making sure that there's nothing that is a small area that can put a high amount of pressure over in a short period of time, or just even a low amount of pressure over a prolonged period of time. Critically important. So those are just some of the broader areas. Others might be identifying high-risk areas with imaging tools, and there's all kinds of really cool imaging tools, from looking at subdermal moisture to looking at inflammation, like skin temperatures, where you can look at for areas that are asymmetrical from one side to another side, looking at hyperspectral imaging, which could also be helpful and has been used in some areas, all the way to other sorts of tools as well, even intelligent bandages and intelligent wearables that could measure some of these things in real life. And we have a whole program now called the National Science Foundation's Center to Stream Healthcare in Place, or C2SHIP, that is working on some of these things now. And I'm the principal investigator at USC for that program, but we have folks working on that as well, all over the United States, all over the world. So all of that's very, very exciting.
Yeah. And really think about all these sort of high tech, advances in terms of technology. But then we also just step back to just do what we know, which is assess who's at risk, position patients properly, do what we can to help them, be able to have mobility. Maybe there's some things that we can do or provide that would help them be more independent in their mobility. And then checking skin. I think of, and I'm sure in the diabetic world as well, how many patients do you see who end up having a wound, and then you find out, so you don't check your feet every day. The most basic principles.
We tell our patients, knock your socks off. If you ever go in to see your doctor or nurse, just knock your socks off, and so that they can have a look, and it'll sort of force people to have a look. But yes, that's absolutely true. But again, there are so many things that nurses and physicians and surgeons and therapists have to do all the time, that sometimes that becomes 11th on the 10 most important things sometimes in an urgent situation.
Could you maybe just give a little teaser about Prelivia and what you know about it, and
sure.
Strategy.
So what this tool is, and what Prelivia is something. So if we understand that in many ways that ischemia itself can certainly at least put someone at risk and exacerbate deep tissue injury, what you have now is you have a tool that might be able to give little micro doses of electrical stimulation intermittently. And what that can cause, it's a really cool, kind of clever idea. It can cause just very, very small, almost non-identifiable muscle contractions. And in doing that locally, can allow that person who wouldn't be able to move her or himself to be able to move. And those intermittent muscle contractions can be skin saving and ultimately life saving if you can mitigate the development or the exacerbation of a pressure injury.
And I like how you called it a tool, just like all these other things, they're tools that we have in our tool belt that we pick and choose for the right individual in the right setting. So again, this is a teaser to all of you who are listening to Dr. Armstrong and I, that one of the sessions that are out there that will be posted is on emerging technologies, and we'll spend a lot more time talking about many more of the specifics and what it can and can't do, and the other emerging technologies.